Hi, welcome back. That was a great session that we had just then, listening to all the real world evidence panelists. We're now going to talk to our own panelists who have been out in the community and have been doing and collecting real world evidence, and they're going to give us their own perspective. So, I'd like to invite Archana first from India to be able to come along and tell us all about your real world evidence.
Hi, Julie, and hi, everyone. So first of all, thank you so much to APPIS and to Novartis for inviting me to this panel discussion today. I'm Archana Panda, based in Delhi, in the capital of India, and I represent Curasimi Foundation of India here. So talking about the real world evidence, first of all, I think the main important aspect is the connection with the patients themselves, the patients and their families and the parents. And in India, what you've done is we have, as you understand, India is a federal country and we have the largest population in the world. So, managing these patients from different states and different cities. So we have coordinators, and all of us are, parents who volunteer to do this work. So the first step that we had done was to collect the patients, parents and families together. And when we were, say, around 10 of them, and my colleague, Alpana, who started this in India, and then we were, say, 5 to 10 patients and parents, families. And since then, we formed an organization, and then we started reaching out to more, parents, and then we collected them. And then that's how we became an organization. Until date, we manage this coordination through state coordinators, and again, who are volunteers, to get the real data from the parents about their needs, the issues they face. So if I talk about spinal muscular atrophy, SMA, as you all understand, it's not just the medicine. There are several aspects in life, and most of the patients, children, are very smart, intelligent, brilliant. So we need access to education. In education sector in India, we have several problems, starting from issues with admission, then accessibility, and then inclusiveness. And then, of course, the multidisciplinary approach, the braces, the AFOs, and wheelchairs. So there are several things that need to be done with patients. So they're understanding the family's needs and what they require, at what stage of life the patient is. So that kind of collection of information, data, right from the parents, is something that we've been doing in India. I hope I answered your question, Julie.
Yes, you did, definitely. Thank you so much. We're going to now hear from Ruth about her country. If you'd like to introduce yourself quickly, Ruth, and then give us your slides.
So, hello, everyone.
We've got you, Ruth. You're on.
Okay, thank you for inviting me. On behalf of Taiwan Foundation for Rare Disorders, I will share the situation in Taiwan right now. So, TFRD is a patient advocacy group, but we also an umbrella organization. So we provide the rare service to 280 kind of rare disease, about 20,000 patients in Taiwan right now. So can I see my slide? Slide 2?
Yep, it's up on the screen now.
Okay. Yeah. Okay. So when TFRD established, in first things we do is push the government to pass the Orphan Drug and the Rare Disease Act. According to the Act, most of orphan drug will be reimbursed by National Health Insurance. So now we have 108 license approval drug being reimbursed. It seems going well, but we were facing new challenges since 2013. In that time, National Taiwan Health Insurance started to implement PBIs. That means National Health Insurance wants to include more professional opinions in the process of reimbursement. Unfortunately, these experts and these representatives they don't know much about rare disease. So consequently, we found that the reimbursement rate of orphan drug has dropped, and the waiting period has extended extensively after PBR's implementation. So the situation made our patients more and more anxiety, and the patient group worry about that they cannot get the treatment in the right time. So to fix the problem, in the past 3 years, Body help patient group to express their need and the expectation of new drugs to the government. So we support individual patient group to collect their drug using experience and the benefit of new drug, especially in aspect of increasing life quality. So then we deliver the patient real world report to National Health Insurance through 3 pathways. The first one, please click. The first one, we deliver the report to Office of National Health Insurance. And the second, we provide the report to patient platform on the website of National Health Insurance. The third, we request the government to share the patient opinion in the meeting or pre-meeting of PBIs. So next slide. So I will give you an example here. So that's the disease called FAP. It's a neurodegeneration disease, and it attacks autonomy of nervous system, heart, lung, kidney, and the digestive system. So you can see here in year 2015, many patients in Taiwan were enrolled in the global trial for FAP drug. But it took 10 years that drug finally get reimbursed by National Health Insurance in year 2023, that's this year. So we look back when the trial was completed. All patients expected a new drug could be reimbursement as quick as possible. But the patients were waiting years by years and it become more anxiety. So TFRD stepped in to help them to establish a PAH patient supporting group so that everyone can get together and we help them to make an appeal to the government. And then we also host a media conference to voice out their need. So for real-world evidence in FAP, TFRD collects patients' experience and opinions through questionnaire survey. In this survey, we would study what kind of symptom the disease will have, and what kind of treatment option, and what kind of improvement they get being treated. And if they are not treated, then what kind of condition and symptom they would want to improve. So after that we send our official letter with a survey report to government agency, as well as patient platform on the website of National Health Insurance. Because the active action of FAP patient support group, the first time National Health Insurance invite the representative to join the pre-meeting of PBIs. So then patient's voice can be heard by government officers. So until now, TFRD also assists a patient support group to collect real-world evidence information and deliver the report through the 3-way to our government. So good news here, 5 drugs has been already reimbursement in the reimbursement list. So that's our experience right now. So we will keep fighting for good quality of life for these patients. Thank you so much.
Well done. That's amazing. Congratulations and thank you so much for your input today. We're next going to have Imjai. If you'd like to come to the floor and we'll listen and introduce yourself and we can hear what you've got to say. Thank you.
Thank you, Julie. Good afternoon, everyone. I would like to share the best practice of my organization. I'm Dr. Imjai Chitapanarux, the chair of Suandok Breast Cancer Network, and also the chair of Chiang Mai Cancer Registry. My organization working to enhancing breast cancer care in the area of limited resources. Allow me to share you my infographic slide. According, could you please, okay, it's shown already. According to the real world data that we have obtained from Chiang Mai Cancer Registry, breast cancer patient right now has increasing in our area, and they are waiting too long for both diagnosis and also the treatment due to the limited resources, including the healthcare professional, also the machine, radiotherapy machine, the chemotherapy centers. And because of in the upper northern Thailand, our people live in the remote area and also in the mountainous area. And the most important thing, they also lack of the knowledge in breast cancer. So we established Suandok Breast Cancer Network in 2002 with the goal of try to reducing the barriers to breast cancer care. And we try to be a training centers and also increasing our healthcare personnel in breast cancer care, and also providing breast cancer care for the patients in 5 provinces in upper northern Thailand. So our mission is in the short term mission goal was to try to overcome the access barrier in breast cancer care. And with the long-term goal, we know that this is quite difficult to get, but we try to increase the overall survival of breast cancer patients. So by encouraging our service network healthcare personnels to give a uniformity of breast cancer care. So we coach them, regular educated them to every levels of healthcare personnel, from doctors to nurses to village healthcare volunteers also. And we also create a shortcut of timely access to breast cancer care. For example, we develop a one-stop service of mammogram and also the pathology clinic in the same day. Also, in case of we have a very long queue for operation, we develop the extra operating room for breast cancer care. For chemotherapy, we try to decentralize chemotherapy centers to our network hospital. We try to create, because that for a long time, we have only one radiotherapy center in our area. So we create radiotherapy queue online request. So on comparing from the beginning in 2002 right now to 2024, we thought that we accomplished our goal. So we expand from 1 university hospital to 5 provincial hospital and also 64 district hospital to help each other in the breast cancer care. We have the new innovation on radiotherapy Q online. From in the year beginning, we have less than 50% of patients to get radiotherapy in a timely manner. But after we develop this innovation, our breast cancer patient can access radiotherapy in a timely manner, which means no more than 6 weeks after surgery or after the last cycle of chemotherapy. That would be more than 80% of patients could access it. And finally, according to the real world data, we try to compare in the early implementation of Suandok Breast Cancer Network and the late implementation. So you will see that we can increase the 5-year overall survival from 71.5% to 73.8%. It would be a very, very low percent, but it increased. So thank you very much.
Thank you so much. That was comprehensive. Really, really appreciate you telling us about that. And finally, we've got on the call Sara, if you'd like to introduce yourself and tell us all about you.
Thank you, Julie, and I'm so pleased and honored to be among a panel of all women who are doing and creating a lot of change in their communities wherever they are. As we have heard that there are a lot of things and challenges that are facing us, but we are not stopping and we are moving forward, and it's great to listen from everyone. My name is Dr. Sara Dallal, and I'm coming from the United Arab Emirates, and I'm a president of the Emirates Health Economic Society. So I come from the other end, where I'm a health economist, and I do work with multiple stakeholders. And what is important is wherever you are as a health economist, you are tying between yourself and the policy shaping in terms you would like to listen to the best approaches from everyone while trying to satisfy equitable access to achieve the treatments that is required. Although what we know is mainly that patient care is very important, but there are things that go beyond patient care and within the whole holes and walls of the hospitals and the clinics and the pharmacies and any other healthcare facility that we can think of. So today I'll be talking about artificial intelligence and why is artificial intelligence being talked about in everywhere at the moment, and why is it important in real-world evidence and real-world data generation. Now, artificial intelligence is gaining a lot of popularity, but the concept was started in the 1940s. Imagine, it's almost a century ago. And this was created in an effect to look at how we can take multiple data inputs and try to understand all of this in a way that could be sensible. We are all aware that there's a lot of challenges that we are facing in terms of generating data. That is on one end, but on the other end, we also have a lot of challenges when it comes to healthcare workers and expertise that would dedicate their time to generate more evidence and do that. Even if we had all the data in the world, there are still limitations with really synthesizing this data and putting it into context to better serve the population. AI since the 1940s have been introduced in multiple areas, and there are multiple studies that may look at one area over the versus area. But overall, whether it was from clinical diagnosis to generating evidence to even looking at different perspectives when it comes to patient care and assessing them at home and really detecting them early, whether it was in the space of multiple areas, rare diseases, or even in NCDs and non-communicable diseases, which poses a great burden on societies. This tool can also help us and can allow us, if it was used in the right and correct manner, to support us with generating evidence and data. So it starts with clinical diagnosis, and it also starts with generating data, but the basis is to get the clear data out there. Probably the challenges that may face a lot of communities is how and where we can start applying AI in generating this data. But the talk today is not how or where. I will just highlight some certain examples that really worked, and it was helpful for us and for decision makers to really communicate whether the disease burden or even the diagnosis was not as accurate and was really probably was not as effective as if we have another assisted tool, just like an AI, to get through that. Going back to one of the biggest examples, which is non-communicable diseases, we have in the UAE applied for non-communicable diseases, and particularly in the respiratory area, an amazing example where in 2023 or 2024, we have looked at how AI can be used with a large data set of claim insurance in terms of early detecting and also looking at the management of cases with their outcomes in terms of a certain respiratory disease, which we know of it as asthma. This means a lot. This is significant when we can tell you that we can model that if what the general practice from a lot of data points can tell us, are we really actually applying our guidelines to the best outcomes and to get us to the best outcomes? Now, we didn't stop at that. The UAE also have a unified, in the Emirate of Abu Dhabi, have a unified electronic health record. So in one city, you have a unified electronic health record. And what helped with that unified electronic health record to build an AI system is to detect risk factors and risk profiles of multiple NCDs, non-communicable diseases, such as diabetes, chronic heart failure, chronic kidney disease, and the others. We know that these are of high disease burden, but they are also costly to the system itself, and also takes away from the further part of the whole society and how we can support the economy of the society. So where we are trying to look at and we are trying to really delve into is using the AI to generate more and more real-world evidence data so it can give policymakers the decision in terms of early detection and early intervening. It's not enough to early detect, but it's also crucial to intervene and to support and even to bring in other sectors, whether it was patient groups or even the social sector, to support us with this decision making. Before I conclude this chat and giving me a little bit of talking about the initiatives, and there are multiple examples where we can think of AI being used in terms of surveillance or clinical diagnosis, or even supporting doctors with getting more of the clinical documentation in shape. What we need to think about at the end of the day, all of us here in this call, that we are doing all of this as we need to really make sure that we are giving our patients the best care available in a more equitable manner. And whatever tool you will be using, probably the UAE might be having certain advantages. That doesn't mean we don't use whatever advantages we have, and we cannot keep the patient at the core of what we are doing. So real-world evidence generation needs to be coming, but you don't need to start with very much advanced tool. And that's what people think when we are trying to advocate for certain things. Maybe certain systems are much more advanced than others, but starting from one point and really getting all stakeholders on that journey with us is the first point to get to that. Start with the disease, get there, look at the data points, and take it further. Thank you.
That is just fascinating. Thank you so much for those insights, Sarah. I'm going to turn around now and ask the ladies some questions. And if anyone has any burning questions to ask as well, that you'd like to ask, please put them in the chat box and I can definitely ask the ladies. But I've got some questions to start with. And I'll go back to you, Sarah. What are the challenges do you see with the use of the use of AI for real world collection in countries with lack of technological advancements? And what can patients do to bridge the gap in the capabilities as well as facilities? How do you see that playing out?
Obviously, there are lots of things that could be technically, from the technical perspective, as multiple challenges. And this can go back to the data quality, to the lack of expertise, just to start with, to some other agencies where we are not very careful. Some privacy concerns can be also a factor that we need to think about, and not even forgetting about the regulatory concerns that may come with it. At the end of the day, it's not about what are the challenges. I think the main challenge is not only the getting and adopting this, but having the policymakers to be with us from this journey at the beginning and getting everyone to understand why AI is required to be used and what will it serve for whatever value that it will bring on the table. And from here, we can see multiple stakeholders joining forces and making these objectives very clear for decision makers and the regulators to put in place not only the partnership methodology of whom should get what kind of information and why does it need to be required, but on the addressing of what are the main challenges, and patient groups can start and work hand in hand and can support in that idea that this will help us in, for example, having access to certain medication. It can have us better diagnose the cases and get them to the treatment as supported with getting into that. And I do believe also with taking into that consideration, we tend not to always forget the patient voice in this matter and incorporating them with outcome research. We say we want to generate data, but at the end of the day, what do I do with this generated data is particularly to incorporate the patient voices and patient way of holding these voices and incorporating it with research to make it much more resonating with everyone prior to taking a decision making on a global scale.
That's a great explanation. Thank you so much. And I think education and relationship building is ever so important in the collection of real world data. We have a question from the audience, and it is, do you use patient voice in health economics and outcomes research? Who would like to tackle that one? Maybe you, Archana.
Of course, we have been trying hard to, reach out to our government of India to include patient voice in every decision making, as a key stakeholder, because I would believe that, the entire healthcare ecosystem, has to be patient centric, because patient is epicenter of the entire health ecosystem. So without patient and patient voice, there is absolutely no use of any kind of decision making that we make. So we were reaching out to government, but then very recently, and in fact, thanks, to all our advocacies, this year, for the first time in India, we had a national symposium on rare disease on the Rare Disease Day, which just happened a few days back on the 29th of this month, February, sorry. And for the first time, we were invited by the government of India as a part of this entire symposium to be a patient voice, which was for the first time in India it ever happened. Because all these years it was we reaching out to them and trying to, tell them, please include us, but then it never happened. We used to force ourselves into such meetings, but this time it was proactively by the government that we were invited. And Government of India has also initiated some kind of a research, the medical research, the indigenous manufacturing, and all sorts of research. It is just the first step, I would say. But yes, there is a movement here wherein a patient voice becomes very important, patient and their families, and government is now keen to gather information from the patients. In fact, I would just like to share another incident that happened, how our voice has helped us in shaping the policies in India. For example, especially it started with, when we had Zolzin SMA GMAP program in India, and the parents, the patient would get the drug free of cost from Novartis. But what about when you have to import it in India? You are supposed to pay a lot of taxes here, and the taxes itself was huge. So we tried to utilize the democratic situation here in India. We have the parliament, we have the upper house and the lower house, we have member of parliaments. So through them, we reached out to the member of parliaments and wrote to the ministry to exempt these taxes. It happened in one case, and then there was second and third, and then we thought it has to be a policy. It cannot be, one-to-one case-to-case basis. And so, when we reached out to the government with these letters, with all the evidences, the real-world evidences from the parents, patients, doctors, HCPs, and, through these voices from the member of parliaments, finally, we had, the budget, we had this declaration in budget. So this is how, gathering the patient voices and then making it at the central level, wherein the government can actually, come up with the policy for the entire nation, and not just SMA, but for all the rare diseases. Yeah.
That's a fantastic example. Thank you, Archana. Our next question is for Imjai. As a healthcare practitioner, how do you think the medical community can support patient groups in collecting real-world data to support health policy shaping?
Oh yeah, I think as a oncologist, so I'm practicing oncology also. So I think gathering data from electronic medical records, so you can get the patient level clinical information. You can from the primary diagnosis, from the medical history, the treatment, the lab imaging, anything. So we will understand the patient and also the disease characteristic and also the real treatment that they get and the outcome from the real treatment that they receive in a routine clinical practice, and try to publish it. And that with this treatment maybe out of date and it's not up to date anymore, and just to compare with the other data, and to make the government, the Ministry of Public Health, to know that maybe this intervention or health intervention is not appropriate anymore. So in Thailand, we also have we call HITAP, or the Health Intervention and Technology Assessment Program. So with our research, we can collect the data and send to them. And this is to HITAP. HITAP is a non-profit organization, the research unit under Thailand Ministry of Public Health. So with this, I think it can shape the policy shaping could make from HITAP also, because they have the responsibility for appraising the health technologies and program, including the new novel drugs or medical devices or other interventions in cancer care or in other disease. So with this medical in the field of medical team, so we can help in this way to make a policy shaping. Thank you.
Thank you so much. That was perfect. Now, I'd like to not exclude Ruth here and ask you, for patient groups with limited resources, what would be your advice to get started in collecting real-world data? How would you advise someone on that?
Oh, yes. Every patient group, I think they have a challenge. We have less resource and less no money to do anything for that. I think we need to organize ourselves, and we should fight for ourselves. So such as TFRD is a umbrella organization. So we should share our resource to each disease patient group. And I think each patient group is composed from patient and the parents. So they should fight for their disease every day. So they don't have more resource to collect the data or fight for the government. So we need organization to help them. And the patient know all the detail, the daily life and the quality of life.
Thank you so much for that. And it's really important just to
So
start
we
somewhere.
learn from them.
Yeah, we do learn. Thank you, Ruth. Much appreciated for your comment there. Next, we're going to put up a poll where thank you everyone for such a fantastic and robust discussion. I've really learnt a lot. I love collecting real world evidence and real world data, but I'm walking away with some new ideas today. So thank you so much. We're going to put up a poll for everyone to do. If you'd like to just please use your buttons to do the poll, then we would greatly appreciate that. We'll give you a minute or so just to complete the poll. And yeah, once again, thank you to everyone that has come along to the meeting. I cannot thank you ladies enough. What a bunch of powerhouse women we have on the call today, and you've changed so much in your respective countries. A huge round of applause, and thank you for everything that you've done. Yes, thank you for everything. You guys have been amazing. So while we're having that quick chat, hopefully everyone has completed the poll now, and we can. Oh, I muted myself. Sorry. It's been a great day for everyone. Thank you so much. I'm going to now pass over to Mahira to deliver the closing remarks for the day. And please don't forget, if you haven't done the poll, to do it now. So thank you and welcome Mahira back.